All right, so here's our off week. This should be relatively quick, but I just wanted to pull up article real quick. Let me share my screen. I just realized that with the Zoom update, I don't know what I'm doing now. So share over so we can see this article. International Journal of Orthopedics is Hallux Valgus and Hypermobility, the first ray, facts versus fiction, or facts and fiction. So this kind of got brought to my attention when I did the podcast with Ivo Warlop, one of the gate guys, that we were talking about the prevalence of bunions and why they occur. And I think it used to be my belief too, or thought process. I shouldn't use the word belief, but that, we see a lot more deviation of the first ray if maybe there's a hallux rigidus there, just there's stiffness through that big toe joint, because then we're going to start finding excess rotation, usually through internal rotation, external rotation at that first MTP joint. And then obviously we get that abducto Hallux valgus formation. What the research denotes, and that's what this is talking about, is that you'll see hypermobility, in particular at the metatarsal cuneiform joint of the first or the medial column or first ray. And then that hypermobility, which then we're going to talk about why it may be hypermobile. Is it truly hypermobile, or is it a lack of control? Which the paper doesn't really dive into a whole lot, to be honest with you, which I thought was kind of interesting because they were looking at more passive motion. But look at the article. I'm going to drop it in the Facebook forum, obviously. And here they're looking at, a lot of different stuff, what's the driver is, but it's a lot more passive motion. There wasn't a lot of like functional assessment around like what happens with speed of pronation, angular velocity, all these things. So, and they even put, does everybody kind of point out here, if we click over, like they're quoting hypermobility. So they're questioning why this is the case in the paper, but findings show that there's more correlation to abductor Hallux valgus or Hallux valgus abductus, however you want to Harry Potter it, or a bunion, class 1 through 4, with hypermobility at that those midfoot joints. So first of all, I'm going to bring up a video on how all of us that have been trained through MPI, how do we go about assessing motion at these joints. So let's watch this real quick. So when we're looking at metatarsal cuneiform joints, kind of just think midfoot in general for this demonstration. We do want to get joint specific, especially if the complaint is in a specific area. But if we're looking at general matches between walking gait and then passive mobility or joint restriction, let's just think that the midfoot needs to do a couple things. It needs to have obviously AP or PA shear. It also needs to have pronation or supination or eversion, inversion. So if we're going to check that on our patient here, we need. So we'll call myself out here. Obviously there are modicums of plantar flexion, dorsiflexion, more so plantar flexion, right? In particular, if you're thinking that as you would go through, let's say, toe off phase across the big toe, what's happening to that first metatarsal? So the head of the first metatarsal is doing what? It's technically plantar flexing, right? Or the whole first ray is plantar flexing, but in relationship, the base of the first metatarsal in relationship to the first cuneiform is doing what? Well, it is extending, and then the first cuneiform is plantar flexing. So all those things need to happen, and that's, we'll talk about why that may not occur, why, it can occur in the first place here in a second. But these are the palpations. Down here, it's a little harder for demonstration purposes. We need to block the rear foot and see if we have AP shear. Make sure when you're doing this, you're not just moving the ankle around. So typically we would come in like this, block the ankle, make sure we cut off right at the metatarsal cuneiform joint in AP shear. Now at the same note, we can take the foot into neutral and then apply a supination, pronation, or rotary kind of movement and checking. Now, something else, we may want to check shear at each one of those joints. A little harder to check rotation in all those joints. So that's more of a global midfoot motion. One of the reasons that we also take it into neutral, you could do it in plantar flexion, which is going to offload some tissue in that orientation. But taking it in neutral, you start kind of getting to the end range of tissue. So if we're looking for joint mobility, it's no different than like doing a seated palpation, right? I'm not just going to go from like start to finish, from like no end range to full end range. I'm going to get to end range. So hopefully wind that tissue up and then joint play there. Otherwise, I mean, especially if you have a hypermobile foot, you're just going to have a ton of general joint play in there. So again, the article points us to the fact that there's more bunions with hypermobility around the metatarsal cuneiform joints, in particular around the medial column. So then we have to kind of propose, okay, let's say there's just general hypermobility. That wouldn't be just hypermobility at that first or medial column. That would be everywhere, which can lead to that. But then we would think, you know, are there, and I don't know if the study's been done, I guess we could look, are there more bunions in people that are hypermobile or have hypermobility just at that joint? So what allows us to lock the lateral column of the foot to then have adequate motion through the medial column? Lateral column of the foot would be everything on the other side, right? So this is the calcaneocuboid joint, cuneiform cuboid, fourth and fifth met against cuboid, like all of that lateral column locks as we do what? So it's going to lock as we go into stance phase and the beginning of pronation, right? It unlocks at the end or the very last bit of toe off phase. So we get that final bit of pronation before we go into swing phase supination. It's important for the lateral column to lock so you actually have proper mobility through the medial column. Otherwise, you can do what? You can have entire foot kind of a valgus collapse, right? That can happen a bunch of places, rear foot, midfoot, forefoot. Or let's say I'm a little bit stiffer person. Now, if I can't lock the medial column, or sorry, the lateral column, I may have restriction at the medial column because your nervous system is going to elicit a response that, hey, if I can't lock the lateral column, I'm just going to crash into it. So you may start to stiffen prophylactically, or you may start to do what? Dive around that big toe. So I would say the most common reason you're going to see hypermobility of that first metatarsal cuneiform joint is the inability to properly lock the lateral column, right? Or sorry, inability to unlock the lateral column of the lateral foot, right? Because if I can't unlock it, I know I'm not going to get to toe off. So I start winding up more around a hallux abductus kind of formation, which again, so just imagine I couldn't get that last bit of toe off phase. Well, what am I going to do? I'm going to kind of like put the cigarette out, as we'd say, where I start spinning around the ball of the foot, pushing off the medial edge of the first MTP and around that big toe. And pretty soon you do that long enough and you literally start creating that abductive force. You start, you know, and I think there's other reasons for this, right? Inhibition of midfoot longitudinal arch support, a variety of reasons, but we're just talking about why there would be hypermobility at the first metatarsal cuneiform joint. It's to make up for rigidness, which I don't think happens a whole lot. It's literally the inability to unlock the lateral column into calcaneal eversion, you know, cuneiform cuboid eversion. The metatarsals, yeah, they matter, but not as much as that midfoot kind of pronation force. So it's just always funny if we look back, even when I was in school, how much, I think we're getting smarter now, how much excessive pronation was talked about. When we know from the research what's actually more important than excessive pronation, the speed or the angular velocity of pronation. And that can get into the debate of hypermobility, and is it hypermobile because you're just going into pronation really fast, you hang out there a little longer than we would like, and we're never accessing the lateral column. And then I know it's always chicken and egg with this stuff, right? Is your lateral column locked because you have shitty control, right? Like poor neuromuscular patterning. So I go in your lateral column and it joint plays well, but when we watch you walk, you stay in a rigid supinated position for most of the gait cycle. Or are you truly restricted through there, right? You lack calcaneal eversion or talocalcaneal eversion, calcaneal cuboid eversion, things like that. That's where we have to do what? You have to do an assessment. I don't think you can. Sometimes you can guess pretty good just based on the rest of the mechanics, but watching somebody walk, rarely do you know, okay, they don't go into eversion because. Now, if you see an asymmetry, one side massive eversion, maybe they're they're truly have a flat foot on that side, pes cavus. The other side is normal. Well, then we're thinking, okay, they probably have adequate mobility. Now they can't control it. So we're probably going to go into maybe the side that isn't, doing what we want it to do. And that's a control thing. Like, you're not playing the guessing game with gait. You're seeing what you're seeing, which should be more of an objective outcome, right? I go to the foot and then I'm checking my palpation assessment, things like that. Like, oh, the joint doesn't move. The joint does move, but they don't access it. Well, what's that lead you to? Am I going to work on the control rehab aspect first, or do I actually need to get this thing moving first? I think we all know that. And again, looking through the coronal plane, just medial and lateral columns here, just showing you, from a soft tissue muscular standpoint, I think we all know this again. Main contributors to lateral column locking that would allow then the first ray, in particular, first metatarso cuneiform joint, to have that kind of cantilever effect would be your peroneus group, in particular, peroneus longus and brevis. Tertius is more of a weak dorsiflexion or dorsiflexor everter. More really, in my opinion, locks the ankle into a position rather than helps move it into a position. But yeah, that's kind of the musculature versus the bony architecture. So to start reviewing on this, because we need to get something practical out of this. Somebody has a little more joint play than normal in their first ray, which I don't think is going to be a standalone thing, right? I think you're going to see general hypermobility of that person if they have, they're hypermobile there, or a lack of control around the first ray, I think is what is going to be far more common, which isn't talked about a whole lot in here. If we cruise through here, they're talking about, the planes of motion, theories on why this would be the case, how they're testing motion, but it's all, passive palpation. Not honestly watching a whole lot of the gait cycle, which is kind of fun or funny maybe, but we need to kind of start determining, okay, why would they have hypermobility there, prior injuries, how, all these things, like, and then it just starts dictating your care. But think of the flip side that we could go around this. If we palpate somebody's foot first, right, and we're looking for, joint restriction and tissue tone change or, excess tension, and then we watch them walk, well, we could almost say, and I tell people this all the time, why do we watch people walk? Because if I palpate their foot and I can feel like, oh, this joint doesn't move, well, you're not going to be able to access that joint. Well, it's the flip side of that. If a joint moves, that does not mean they access it. That's why we still have to watch them walk. And that's what this is talking about, because we don't know, is it true hypermobility or lack of control? That's where I think they're saying from a passive standpoint, hypermobility, but I would then go in and be like, well, can you control that hypermobility? Because almost every elite gymnast in the world is going to present as hypermobile, whether they've trained themselves in that position or they had a genetic gift for it. But their ability to control that, as we were seeing in the Olympics, is probably far better than our normal mobility would be, even though they're going to have access to much greater ranges. So if we palpated their hip joint, and AP shear, posterior translation, I bet their hip moves a heck of a lot more than mine. I also guarantee you they have a lot better control of their feet. So, hypermobility is a thing, right? Testing Beighton criteria shows hypermobility. Does that determine functional outcomes? No. I think that's where we need more studies, and I should dig into that a little bit more on, is it true hypermobility or is it the lack of control that's the driver there? I would say far more control, because I know a lot of very flexible people that have great control, aka gymnasts that don't have a lot of bunions. I know a lot of gymnasts that have bunions too. But that would be kind of interesting. So I just wanted to point this out, because I think my first thought process was, well, I thought it was a lot of stiffness around that first ray, medial column, first MTP joint. It's not. It's going to be mobility issues or control issues. Okay, then how do we make sure that we're looking at a mobility issue or lack of versus a stability issue? Well, then that determines our treatment or, a jumping off point. So again, that's hopefully what we're doing with research, right? Just it makes you think a different way. And if you saw enough of these cases, you'd come up with that conclusion on your own. But that's why my thought process is a little bit different than the research is. You'll see a lot of people that walk with speedy pronation that are pretty stiff palpatory wise through the medial column, right? They still have shitty control. I think one of the reasons that they're stiffening on passive palpation is to help control that, right? Whatever they're trying to do, lay down trigger points in, abductor hallucis, whatever the musculature that we want to pick on for pronary, whatever it is. But that speed of pronation, the angular velocity is a bigger deal. And then if we see that, and then we go in and we're palpating like, man, there's rigidness there. What I would say at that point, which this is the flip side, and Courtney Conley talks about this a lot. Let's say I have palpation of some, joint restriction or tissue restriction around, first cuneiform metatarsal, and then that first MTP joint, either one. So if I have rigidness there, do I just blast away with mobility stuff, which, yeah, we want good input, but what do we know most of the input in the foot comes from? Slow twitch muscle fibers and the muscle, not so much the joint, versus like big joints like shoulder and hip. I may want to look at their ability to lock their lateral column, because if I give them that neuromuscular control, which goes kind of more in the DNS model, what may we get out the other end of the medial column? Mobility. So again, you're always playing this big, like, it looks like a recycling sign of like, okay, where do I enter care? And then that gets me the best results. Because you could absolutely just go in, adjust a bunch of stuff, right? Do some like, general foot doming and things like that, saying, oh, we're going to try to stabilize. Or you could literally just do mobility stuff. And then the neuromuscular pattern with walking and things like that may improve if you can keep mobility in there. But I think that would be a very archaic chiropractic approach, PT approach, right? Just blast away on joints, get movement, do it enough that hopefully the neuromuscular system adapts to it. I just thought it was interesting. Tom Michaud talks about this a little bit in a couple books, in particular, the Injury-Free Running, the second edition that I've been going through here. We'll be pulling some stuff out of his other research articles and that book and upcoming stuff. I was going to dive into, I have another article on lower step rate is associated with a higher risk of bone stress injury. I think that makes sense to most people. That's why I didn't go over it. So that it's saying if I have a higher cadence, I'm going to have an instance of less bone stress injuries. That's been talked about quite a bit. And then the other one was the functional importance of human foot muscles for bipedal locomotion. I don't think we need to debate that very much. I think we're all wise or hip to the fact that, like, if you lack foot intrinsic control and strength, that we're going to have a higher incidence of injuries, functional deficits, higher likelihood of falls. The one interesting thing that gets brought up quite a bit, Tom Michaud brought this up. What's his name? What's his last name? Beard. Ultra Running Podcast had, I'd have to look up the episode, but talking about how fast you have atrophy of the muscles of the foot going into a rigid orthotic or shoe is about 2 weeks to get about a 30% reduction in muscle belly thickness. Getting somebody out of shoes, it takes almost double that to get that back. But that is not determined function wholly. So just because I have thick muscles does not mean that my foot works like it should. So it's not, it's just, I think that makes sense, but like, that's a lot of like rehab nowadays. Like, get general strength back, and all of a sudden you're, if your hamstring, quad, and hip are strong, your knee pain is going to get better. You may still operate around that knee really in a shitty manner, which, it's kind of what we talked about with the foot stuff today. So I hope I didn't ramble all of you into confusion on that. I hope I summated it pretty well there at the end, that, just go through your process, make sure your jumping off point, you're doing a full assessment, you're not guessing on either end, which I don't think any of us do, but you can very easily, bang on a stiff joint and not have a plan or not a proper assessment to look at what may be driving the bus on a hypermobile or stiff joint. So there you go. Hope you guys got something out of that. I will see everybody next week at Grand Rounds. If you have any questions or anything, drop them in the Facebook forum, and I'll see you then.